messages from the UK. That's totally the opposite system as the UK, but I cannot conclude if it works or not. Okay? As disclosure, I've been involved in CME, CPD in different parts of the French system. Currently, I am retired and doing some consultancy, but anyway, I've always been quite free in my language. Okay, so it's sometimes quite difficult in the French system. Yes, you've read a short editorial in the BMJ. Thanks for your help. And I will give you some clues of this editorial, because currently in France we have officially a mandatory system. Officially it's mandatory, but we have no credit system, no control, no peer review system, no revalidation, and no harmonization with Europe. So is it possible to survive like that? And clearly, I want to go back a little bit to the history to understand that still the history is playing a larger, has done a lot. Because CME, if you go back to 40 years ago, it was in the hands of general practitioners. And they have set up everything, the rules, implementation by themselves. And they were fighting at that time, still today, with hospital doctors. So once the government comes and it's hospital doctors explaining to GPs how to do, they say, no, we know how to do. Okay, we don't want to do. So it was the GP's leadership, it was in the end of the industry, as in many countries, but in 1980, the government and the Sécurité sociale start to give funds to medical unions to take care of CME. And I mean by medical unions, mostly GPs medical unions. So they started to give money and tell them you have to organize CME. Not exactly to organize, because the contract between the funders, the Sécurité sociale, was we will give money to doctors for attending CME events. By money, it's the equivalent of 15 visits. You will not see patients that day, and today you receive 350 euros if you attend an event. The provider receives also money at the same time, and most of the providers are medical unions. So you see the game. And this book, concluded by a guy who is still quite influenced, relations between medical unions and training associations have represented one of the most hectic aspects of the history of FLC, which is CME. It was for the last 20 years in the 90s. So still, probably today, it's totally valid. Another thing which is quite important, hospital doctors can leave their work to attend CME events. And they have 15 days they receive per year, they receive their salary, and they can go and attend CME events. And they partly use that. It means 3 weeks, it's quite a lot, and it's a marvelous system. It's marvelous. They can go, but they also explain that they want money to go to attend events, but they don't get money for that. Okay? And one day, by chance, it was a former prime minister who decided to put mandatory CME in the law. It was in 1996. It was in the law. Okay? We have to understand that demography of physicians is declining right now. Okay? And when the number of physicians is declining, it's much more difficult to explain to them, you have to do that. You have to do that, and you have to do that. So they say, we are overloaded, we see too many patients, we don't have time, we have no time for seeing. And our system is 50% GPs, 50% specialists, and it's the same. 50% are private, have a private practice on a fees for service, and 50% receive a salary. So it's always difficult to have the same rules for those two kinds of doctors. So from 1996, we had every 3-5 years a new law explaining CME is changing. What was important, it was in 1996 it became mandatory. In 2002 we had 3 national CME committees, one for private practice, private doctors, one for hospital doctors, one for the others. It started to work 3-5 years, and that time it was decided to stop everything. Okay. They started to accredit providers. We had 500 providers. It was starting to work a little bit, and then the government decided to stop all the system. Okay. Explaining that it was due to the EU regulation. It's not clear at all. Okay. And in 2004, it was decided that CME is not active, it's not interactive, and we have to move on to continuing quality improvement, and that's all. And to stop all those events. Strange. So if you want to understand today's system, you have a lot of websites, and the decision that was made in 2009 that it is exactly the same system for 17 professions. So it didn't work for doctors, but it has been decided to implement the same system to 17 professions. So you have a podologist, oh, what's happening? You have nurses that start a little bit. And if you go to the official gazette for the law, you have 150 pages explaining the system. I don't want to go through the system. If you want more explanation, I will explain to you that we have a lot of actors. And it's not only one of the actors is quite important. It is the OGDPC, Organisme Gestionnaire du DPC, which is in the hands of the funders, the Sécurité Sociale, and they have set up in the last 3 years a body with 50 employees, and their objective is to coordinate the system. So it was just installed starting in 2009. It took 2-3 years to set the rules, and they received 160 million euros to run the system. Okay? At least 1,000 million euros should be involved in the system. So today we have 3,000 providers. The actors, you have the organism, you have the National Health Agency, you have specialty, medical specialties, but the so-called French Medical Association, which is called the CNOM, Conseil National de l'Ordre des Médecins, doesn't want to be involved really. He's involved in the competency when you get your diploma and your license. So I've got my diploma 35 years ago. I stopped seeing patients 20 years ago. If I want to open surgery tomorrow morning, I just have to pop and I can see patients the next day. That's a marvelous system, you know? No? Okay, I have nothing to do, okay? It works well. So the methods, the CPD methods, we have books of CPD methods, and most of the professionals don't understand, because now we have 28 different methods. Yes. Attending a staff, a group of doctors, okay. And which is marvelous, every 3-5 years, the Minister of Health says, oh, it doesn't work. Okay? So we have a system of auditors. There are inspectors. We have in the healthcare system about 80 inspectors, old guys, one in a specific body. And you ask to those inspectors, you will spend a year and you will tell me if it works. So the last report was in April 2014. Those guys were very competent, very good guys. Okay? I'll give you the 4 conclusions. The four conclusions and the 4 scenarios they proposed to the government. The 4 conclusions in 2014 was the design of the system was poor, governance of the system was unclear, and the independent scientific committees that assessed the providers were of poor quality. Half of them never declared their conflict of interest. For example, it's mandatory, but nobody declares. That's not this. Project management was also inadequate, with poor technical choices of IT systems. Deadlines were too short. You have to set up your dossier by next month. No. The system was criticized for allowing drug companies to sponsor CPD and for the use of too many private rather than public or non-profit providers. So it was the cloudy atmosphere. And they have suggested 4 scenarios. All 4 scenarios, all solutions entail a reduction in the government's role and an increase in the professional responsibilities. You know, they are paid by the government. Okay? And clearly, you have to change and you have to decrease the power of the government. That's clearly the main conclusion. You have 4 scenarios. Keep the current system, but simplify its internal process and governance. Limit the official body to interprofessional education, public health priorities, with other goals dedicated to professionals. Because in the interview we have CPD priorities, which are published in the law every year. You have 30 priorities every year. Third, professionals should set their own education needs, select their providers, and start thinking of a revalidation process. Start thinking.
It took us 12 years.
Yes. It could take us 30 years. Continuing education being a professional obligation, the body or GDPC should be abolished, and the money used to fund incentives to undertake CPD. So you are the Minister of Health, you have this report. And the report says you have to take one of the 4 decisions. What is the usual way to take a decision? It's no decision. They never took a decision, which is the best way to survive in such a system, because if they had said 1, 2, 3, or 4, it was a war. Okay? Okay, it was starting to new battle. So no decisions. No decisions. I end up with a few slides. Are hospital physicians competent? We have no data. When we do surveys, most of them say they use their free days to attend meetings, so they go everywhere. Nobody controls. We have no ID, and they complain to the hospital because the flight ticket is not paid, and which also can understand. Private physicians. After 5 years, 27,000 private physicians out of 100 have created a dossier. To create a dossier, you put your name, diplomas, and bank account numbers in order to be paid. That's all the dossier. That's all. So, at least. The show must go on. 2 days ago, a new law was passed. Healthcare law, and there is 3 pages about CPD once again. It was signed 2 days ago by the Minister of Health. So we will replace this body by a national agency. We will have a national agency for CPD. A new CPD definition. Each time we have a new CPD definition. New CPD priorities. No more funding. That's very clear. Medical schools will enter the game. It means the part of the cake is 150 million euros, 160 million euros, and it means that 40 million euros will go to medical schools. So you will see the medical unions from private GPs and so, they will start to cry. And 160 million euros, it's not for doctors, it's for 17 professions. Okay? So they started in 2015 to fund CPD in September because they have no more money. So they funded events up to September and then they stopped. more money. And we will start in January. Okay. The new definition says, formerly doctors had to comply and to make one CPD event, one CPD action per year. Now it will be every 3 years. That's the main decision of the new definition. EU, we don't know what is EU. Nobody cares. Sorry to tell you that, okay? We know that there is this EACCME, but it has nothing to do with our system. We don't care at all. So Pierre Gallois exactly said in nearly 20 years ago, that, and I can say exactly the same. Relations between medical unions and CME CPD funders have represented one of the most hectic aspects of the history of CME. Merci.
Thank you, Herbie.
I could be killed anytime.
Is there anything positive for the future?
Joker.
Comment? Can we have France anyway?
Yeah.
Thank you very much. We have to go on because our time is limited, and our next speaker is Vijaya from the Italian Federation of Medical Doctors, Surgeons and Dentists, non-SEO. And Enrique Repenasa, we are always discussing CPD, whether it should be voluntary, mandatory, and so on. And it is most interesting to hear Sergey's opinion on this matter. Please, Sergey.
Thank you very much. Thank you for this invitation. And I have to apologize for my limited English language skills, which unfortunately will hinder my ability to verbally interact with you now. Nonetheless, please do not hesitate to contact me by email. I will be very happy to answer your question in writing. In Italy, my country, our CME system was created as a tool to maintain, develop and improve clinical knowledge and clinical skills, as well as technical and managerial skills of health workers. Aiming at ensuring that healthcare provided to citizens by the national health system is effective, appropriate, safe and efficient. Mandatory professional update has been designed to make sure that all health professionals have the possibility to keep improving their knowledge and skills without having to resort self-referential study once they have obtained their professional habilitation. Our national CME program started in 2002, following the provision of Law 502 and Law 229, which made continuing medical education mandatory for all health professions. Anyway, law obligation aside, good health professionals always had and left an ethical obligation to provide care to their patients by constantly updating the skills free from interest conflicts. The ECM system in Italy is regulated by the National Commission for Continuing Education. It's chaired by the Minister of Health and counts 35 members who are appointed by the Ministry of Health 10 members, the State Region Assembly 9 members, and the National Federation of Health Professions 16 members. In my country, the National Commission for Continuing Education lays down the rules, quite complex in my opinion, very complex, concerning continuing education, which pertain to both targets, professionals and education providers. In order to build a national database of CME credits, acquired by health professionals within the Italian National CME program. In 2003, was founded the Health Profession Databases Committee, COGI-APS, answering to a need felt by all health professions and by their own initiative. The Health Profession Databases Committee is therefore a tool serving every association of health professionals, as well as institutions dealing with CME at any rate. In Italy, CME was introduced resorting to a step-by-step approach. The years between 22 and 2010 saw a very long experimental period. CME was compulsory by law, but compliance was not verified. It was left to goodwill of each professional. In those years, the National Commission for Continuing Education ruled that the training needs of each professional amount to 150 credits every 3 years, 50 credits per year. At the end of each 3-year period, only professionals having acquired sufficient credits can be awarded a CME certificate by their professional body. The first 3-year period for which Italian health professionals were able to obtain their CME certificate was 2011 to 2013. The following 3-year period is 2014 to 2016. Starting from January 2017, professionals will be able to apply for their new certificate. Each professional order is linked to Health Profession Databases Committee. Through it, the training situation of a professional is verified and a certificate is produced. Each professional can personally interact with the Health Profession Databases Committee as well to check his or her own credits and point out any inconsistencies. The Health Profession Databases Committee currently holds data regarding approximately 30,500,000 participation to ECM activities, generating over 244 million CME credits, pertaining to over 1 million CME accredited events, either at the national or regional level. More than 1,100,000 health professionals are registered as such in Health Profession Databases Committee. These data are a measure of the breadth and capillarity of the CME system in Italy, obtained thanks to commitment to producing an ever wider training offer and by involving all health professions in the CME program. For the 2011 to 2013 period, over 358,000 professionals obtained their CME certificate. Regarding the medical profession in particular, over 300,000 doctors are currently taking part to the CME program. By the way, our CME logo is the famous picture by Rembrandt. Young doctors who are specializing in postgraduate schools are temporarily exempted from CME duties. For the 2011 to 2013 period, over 150,000 physicians, 49% of their total number, could obtain a certification proving their compliance to CME duties. In the same period, another 160,000 doctors took part into some CME activities, but not enough to obtain a CME certificate. Similar results are expected for the 2014 to 2016 period, according to trend data. Now some more and more frequently getting required by employers. Its lack does therefore translate into a handicap for those professionals who cannot provide sales. On the other hand, with the exception of specialized in occupational medicine, currently a CMA certificate is not proof of having performed CME activity pertaining to one's specialization, meaning that the CME total credits of a professional add up to those obtained from every CME course she attended, either or not consistent or relevant for his her specialization. A situation, this one, with the potential to generate opportunistic behaviors, such as choosing activities looking at the CME credits they generate, rather than to one's own educational needs. In summary, the current Italian CME system, in my opinion, is characterized by strength because it is an important element in the governance of a profession. It is a guarantee for citizens and for institutions. It is a resource to ensure quality training. Weakness. One's CME certification is not proof of one's acquired skills, but only of knowledge. Opportunities. Each professional is provided with a certificate proving his or her continuous education to be valued in an European market open to citizens and professionals. And last but not least, risks. Attention centered on formal compliance may result in leaving the CME's real purpose in the background. We are aware of the limitation of the current CME system in Italy and of the need for it to be geared towards pursuing real continuing professional development. Until we will one day get to implementing periodic revalidation of one's professional skills. And we are striving to drive along this road. Thank you very much.
Thank you, Fabio. It's problematic when 50% of the physicians can't live up to the standards or the settings. What kind of sanctions will they have?
If I can, my friend Enrico Reginato translate for me because I speak. Ok. Dunque lui chiede perché le sanzioni non sono state applicate.
In sostanza sì, perché il 40% non si dà e non sono state applicate le sentenze.
Allora, la metà dei professionisti fa formazione ma non raggiunge la certificazione, cioè non la fa completamente.
Half of the professional, they follow the courses but they don't fulfill them completely, so they don't reach the maximum they need to.
La fa in parte.
They're only partial.
Poi le sanzioni non sono state applicate perché avrebbero dovuto applicarle gli ordini professionali, ma gli ordini non hanno trovato un accordo ritenendo che l'offerta formativa in Italia non sempre fosse adeguata alle reali esigenze dei professionisti e quindi diventava difficile applicare sanzioni quando non era completamente possibile avere certezza di fare una buona formazione.
Well, the sanctions were to be applied by the medical association, but the medical association didn't do that because they didn't find a real agreement on what was to be done in order to be in favor of the real development. So they up to now, I could add on myself one more answer that Italy is just now applying the European Working Time Directive that was not applied in the hospitals. So with the cut of resources and
in Sweden we don't count any credit points, but the Swedish Medical Association, they have recommendations regarding participating in CPD. And they say it should be a minimum level of 10 days a year, and you should have 4 working hours a week that you can spend for own CPD activities, or if you have something common in your department. And each second year, the Swedish Medical Association makes an inquiry, and I apologize just because the text here is partly in Swedish, but I didn't have the time yesterday to fix this. But if you look at the blue line, it is how many days Swedish doctors in need spend for external CPD activities, courses and conferences. And in 2004, it was almost 9 days. There is a decrease over time, which we think has to do with underfinancing of the healthcare system in Sweden. But regarding internal CPD or hours that you can spend in the hospital, there is a slightly small increase, but still we're not up to more than 3 hours a week. A big problem in Sweden is the GPs, because when we take the GPs and see how much external CPD activities they participate in, it's only 6 in the year 2007 and 5 days a lot of our doctors are females and they are on maternity leave. And if you get this inquiry and you have to say in 2012, I did spend so many days on external CPD. No, I was at home on maternity leave. What should I click? It's not that easy. I mean, these figures are used by the Swedish medical association to put pressure on our employees and say, look here, we don't even reach up to the standard of 10 years a day. You must do something, you must get us more money, we must have the time to spend on external activities. And this is the way we use it. Yeah. Andrew and then Joseph.
It does seem to me that we are trying to invest in a system that I think is old-fashioned and outdated. All the evidence suggests that you learn in a conference or in an external CPD event by interacting with colleagues, not necessarily by what you hear from plenary presentations. And the truth is the internet has now made both the interaction and the ability to get received wisdom much more able to be done asynchronously. And so I suppose the question is at the moment we're measuring the things which are easy to measure, i.e. the number of days you go around conferences, rather than actually measuring the type of things which actually facilitate learning.
I agree.
Where is the e-learning in this statistic? External or internal? E-learning.
In this inquiry, e-learning was never asked for. Enrico and then Joseph.
Thank you. Well, you said at the beginning that we discussed a lot about the problem of continuous professional development. Well, I always admired the huge amount of work you have been done about it, and we also agreed, but on one field. I sustain that as we have a free circulation of doctors across Europe, anyway, within a European rule that allows complete autonomy of states in organizing their health system and whatever is there inside, so working conditions and so on. Well, I think that given this free movement, only to trust in the national declaration, well, I would like to have a system of measure that could be supranational, because people receiving, countries receiving specialists from other countries should be in some way alerted on the real professional development they made, not only, well, when I talk about it, you know, the most feeble point, I know Italy, of course, better than other places, the most feeble point of postgraduate education in Italy is that, is not done, even the Italian law is not respected, so it's difficult to accept that an Italian specialist is the same as valid as a German or French one. So there's a problem. In Italy, we limited our development to continuous medical education. And also there, Professor Grandis morning showed us how multiform can be the mechanism of learning. And also the problem of measuring the credits has always something arbitrary inside. And among the pitfalls in our system in Italy, one of them is that, like Sergio said before, that you are sure about the culture but not the skill, because it's demonstrated that front lessons, they don't change the doctor's behavior, and the CME is done only by front lessons. And another pitfall, and after I stop, is how you calculate the credits. I mean, if somebody goes, working for 2 years in Great Ormond Street cardiac surgery, pediatric cardiac surgery, comes back, well, it doesn't give him any credit. But if a surgeon from Great Ormond Street comes to Italy and makes a lesson of 5 hours, he gets 5 credits of that. So I think that it is not exactly appropriate the way we calculate the credit. So it's still a kind of too arbitrary system of calculating.
Thank you, Enrico. which have their own private pockets, they run their own business. And of course, they have more ability to put aside money to participate in these activities. And in the northern part of Sweden, there are no one wants to live up there because in the winter time it's very, very cold and very dark, and you hardly never see the sun. And on the other hand, in the summertime, it's the sun all the time. It's a strange kind of living when it's very north. And it's also very expensive to send these GPs for different courses and conferences because there are not that many ranges. I mean, it's a small population and it's very costly to make courses and conferences. So you have to have another view on how to learn. And I think we are regarding CPD and what will be the future. We are very much in the beginning, and I think 10 years from now we will be much further, and we will have totally another thinking of CPD rather than we have today. And we can only turn back when we were here 10 years ago and at the same conference at that time we were discussing that physicians should have a computer. They should have access to a computer in the hospital. And it's only 10 years ago. And now, is there anyone in the room who doesn't have a computer and access to normal information on the internet? I did answer your question.
Still one question. There are some differences between countries because I have heard there are countries which have the own politics of CPD. The own politics, regional. For instance, I have heard about Jönköping and integrated healthcare there.
Yes, the system in Sweden is voluntary, but it's the pressure from the National Board of Health and Welfare on the employer, not on the employee, and that's very important. That the employer must assure that the staff, that the GP that meets the patient actually has the knowledge that the patient demand. And that's very important. So it's but for the GP who sees the patient, it's only an ethical obligation to participate in CPD activities. And they do. I mean, I think we all do. Janet?
Is that sound? This has been really fascinating, and I think it's also been, excuse me for saying so, really worrying, really, really worrying. The which they're not. So I think we need to examine the assumptions that we're making here. And the assumptions that we're making about effects on practice, nobody has shown that there's any effect on practice. So why do we still assume that the systems that we've got at the moment do have an effect on practice? We're walking on for many years hoping that we will be able to show this, but we haven't been able to.
Wait a minute, we all go to school.
We do all go to school. Now, and that's interesting. That has some results. We all go to school, we all go through a curriculum, we are all assessed on it. That is not the same as CPD. That is a different thing. I believe that doctors learn, and I believe that learning is a good thing. And I'll tell you something, nobody knows how you learn to read. Nobody knows that. We change it every 5 years. You can read, you can write, and nobody knows also how you learn to write. We change our views. I speak as an educational psychologist, and nobody knows how you did that, but you did do it. And doctors continue to learn. You all, I keep saying that. I trust you all. I'm a patient. I don't need your revalidation certificate. I don't need your CPD certificate. You all learned, and we don't know how. So why bother to give credit because you did a phonics system or you did something else? So the point that I'm making is not education is bad. Education is good. Learning is good. You all do it. You do it. We're talking now about the parallel universe of CPD. That is something different. Yeah, go on. Okay, we're making assumptions that the elements that we've identified are good elements, and then fiddling about those assumptions. Anyway, that's one thing. So I think we need to look at the assumptions. We need to look at the context. And one of the things that we haven't done, you were talking about, does this send people away? Do we make people redundant? Do we push people out of the healthcare service through revalidation? No, we don't. They're just retired. That's it. And if you're retired, apart from your father, why would anybody bother to go through that? So they're just retired and they're establishing it. They're retired. That's fine. But the context that CPD has is a context of the healthcare service. And we've heard people say that we're struggling with CPD. The healthcare service is in decline. It has less money. It has fewer people. It has more demand. So there's a context there, and it's different in different places. And then we haven't really talked about what the purpose of CPD is anyway. So it's everything. It's everything to everybody. So what is the real purpose? Because different purposes will have different solutions. So I think that, and you're in an ideal place, Minister, you're in an ideal place to actually start asking these questions rather than following lemmings. So I think that there are those questions about assumptions, about context, about purpose, and what's the problem we're actually trying to solve. What is the problem? And the problem, is this the answer? And there are other things around that, in that context, which are about the healthcare service itself and whether it's functioning. Ours certainly is in decline. Whether managers, and you mentioned this, might take responsibility for the people they employ, whether there's evidence and so on and so forth. So all I'm saying here really is that I think one reason why this debate doesn't actually move on very much, and it doesn't move on very much, it is constantly another thing about credit and say, is because it's like that position when you've known someone for so long you don't like to ask them their name. And I think that we've been doing this CPD for so long that we're frightened now to go back and say just stop and look at the assumptions, look at the context, look at the purpose, look at the problem, and let's see if we could actually have a sensible conversation about designing something different rather than trying to massage something that we haven't yet shown to work. And I really think that we could do that. I really do. Because you do learn. Of course you learn. So why don't we do something that's relevant to that?
Thank you very much, Annabel. With 5 minutes left, we have 2 more speakers, not speakers, comments. First, young man in the white shirt, and then the gentleman will have the last word.
done by non